For millions of men, no amount of diet or exercise resolves the appearance of an enlarged male chest. This persistent volume is composed of permanent glandular tissue, which remains biologically unresponsive to traditional fat loss efforts. This cross-section reveals why training fails. The chest has 3 layers: skin, yellow fat, and red muscle. In true gynecomastia, a dense glandular mass forms behind the areola, between the fat and muscle. During exercise, the muscle expands, but the gland remains completely unaffected. This creates a visible disconnect. Because muscle hypertrophy increases the size of the base layer, working out pushes the unaffected glandular mass further outward against the skin, making the condition more prominent. Mechanical gym effort is physically incapable of reducing glandular tissue. It is a biological impossibility to work out true gynecomastia. To understand the origin of this tissue, we have to look past gross anatomy and zoom down to the cellular level. Specific chemical triggers force the male body to grow breast tissue. The baseline male body requires a strict chemical ratio, high testosterone vastly outnumbering a small trace of estrogen. When disrupted, estrogen binds to local chest receptors, signaling the structural glandular mass to expand. These hormonal fluctuations naturally occur during 3 specific stages of life: gestation in the womb, the onset of puberty, and aging past 50. External chemical catalysts can also artificially induce this shift. Specific prescription medications, anabolic steroid use, and underlying medical issues like thyroid or liver disease all disrupt the hormone balance and trigger tissue growth. True gynecomastia is a chemically driven condition independent of lifestyle choices. A patient has zero mechanical control over the cellular onset of the gland. Visual surface symptoms are rarely enough for a diagnosis. Many patients mistake standard chest fat for a glandular condition. This split screen reveals the internal distinction. The bottom half shows pseudogynecomastia, where the chest wall is expanded solely by soft, uniformly distributed yellow fat cells, lacking any structural glandular tissue. Since this volume is composed of standard lipid cells, pseudogynecomastia shrinks in response to a caloric deficit and cardiovascular exercise. True gynecomastia, on the top half, behaves differently. Its dense, fibrous characteristics ignore fat reduction entirely. Even as surrounding yellow fat cells shrink away, the rigid glandular mass remains locked in place. Identifying the condition requires a physical test. Palpating the chest reveals a firm, rubbery, and sometimes tender disc located directly under the nipple, contrasting with the soft feel of regular fat. Distinguishing the correct tissue type is mandatory. Misdiagnosing a glandular condition as a weight issue leads to years of wasted physical effort. Today, medical consensus states that once this glandular tissue has solidified, it requires targeted surgical excision to be completely resolved. First, a minimally invasive cannula clears away surrounding excess fat, isolating the glandular core. Then, the surgeon physically excises the firm glandular mass through a tiny incision, allowing the skin to sit flat against the muscle base. These offending glandular cells cannot regenerate once they are physically removed from your body. This results in biological permanence. The chest is flattened instantly. Following the procedure, a brief period of wearing compression garments ensures the skin retracts correctly to the new masculine contour. A chest that fails to change through years of physical training is a biological reality independent of effort. Precise medical intervention provides the only permanent reset for glandular tissue.